Hello and welcome to today's webinar with Mingle Health. Our topic for today is getting started with MIPS and the key changes for 2018. Mingle Health is your partner in the transition to value-based care and helping providers and practices improve what matters. Ask us how we can help you streamline your workflows, improve quality scores, and increase earnings. Some items before we get started with today's webinar. This webinar will be recorded. The slides and recording will be sent by email to you later this week. You may also download the slides now from the handout section of the GoToWebinar to follow along as we present. We encourage you to ask questions throughout the webinar using the question box. Our team is standing by to answer them, and we'll save plenty of time at the end of the webinar for additional questions and answers. Our presenter for today is Hadley Taylor. She's an expert on the Quality Payment Program and has helped hundreds of practices succeed with MIPS. Hadley, over to you.
Great. Thank you, Red. I hope everyone is doing well this afternoon. I'm pleased to be here, and I'm glad to see you all here too. So let's dive into MIPS, a fun and exciting topic, which we hope to make at least interesting as we go through this. We're going to talk about the overview of reporting. We're going to go through eligibility criteria and requirements, and then we'll talk about how we at Mingle can help you get from point A to point success with MIPS and answer any questions that you have. So, as you may know, MIPS is the end result, the result of CMS trying to streamline quality reporting. There were many programs that were in line, meaningful use, PQRS, et cetera, all with different overlapping due dates and requirements, and it was indeed a hassle getting this all done. So CMS decided to merge it. Quality, which used to be PQRS and the value modifier. Cost used to be just the value modifier. Promoting interoperability is the old meaningful use. And then we have the new kid on the block, improvement activities. That is a new category. I love it. It's easy after all the stress and strain of the rest of the measures, the rest of the pieces. So what does this mean for you? This means CMS wants you to report. You will be hit with a penalty if you don't. There are various ways of doing this, of course. That's part of what we're here for, mainly to keep you from getting any of these penalties. In the payment year 2020, if you don't report for 2018, you will be hit with a 5% penalty, and that's going to keep on going up through 2022. 9%, it's a scary number. So what are we looking at? We're looking at a point system. You must report at least 15 points to make sure that you do not get hit with a penalty. You can, however, aim for an incentive. That comes with the work that we know that we can do together. We're looking for anything over 70 points. That's going to pretty much ensure that you get a positive adjustment in the payment year 2020. So what are the pieces of this? Quality is indeed the biggest part of reporting MIPS. It always has been. Even when it was PQRS, it was bigger than meaningful use. Same thing here. It is 50 percentage points. CMS wants you to report on 6 quality measures. A quality measure, for example, would be A1C. Did the patient have an A1C run, and was it better than 9%? Or med reconciliation. Both of those are high priority measures. CMS has a vested interest in making sure, for example, that you know what meds your patient is on or how your diabetic patient is doing. There are close to 400 quality measures to choose from. We've always had success with finding measures for a practice to report on, regardless of the specialty. So CMS wants 6. One of them has to be a high priority, and you're going to report on 60% of the patients who are eligible for a measure, and it's going to be for the entire year. Let's take a little closer look at that. Just a brief snapshot of what our dashboard looks like to help you find measures with your consultant. The next part is closer to the 60% piece that I was talking about. So let's say, for example, that your practice wants to report on Measure 24, communication with the physician or other clinician managing ongoing care. These are examples of quality measures. This right here, the 499, is the eligible instances for this fake practice for this measure. That's where the 60% comes in. It's not 60% of all of your patients. It's 60% of the appropriate patient population for a measure. And that same thing goes all the way down here. Say, for example, you decided you wanted to report on Measure 48, the urinary incontinence measure. You're going to report on 60% of 2,300. That's where that comes in. That is something that your consultant works with you on closely, figuring out what measures work for you, what measures speak for you, and frankly, the lowest number that you can get away with reporting in those measures. The next piece is promoting interoperability. This is the old meaningful use piece. This is worth 25 percentage points. There are between 4 to 5 measures for the base score that you must pass. So, for example, if you have a 2014 CERT edition for your EHR, you need to pass 4 base measures. That's e-prescribing, security risk analysis, patient access, and health information exchange. This is something, too, that your consultant helps you with. As a reminder, CMS is strongly encouraging, pretty much mandating, that for 2019, your EHR be at the 2015 CERT edition level. Just a small aside there to remember. This is a screenshot of how our dashboard looks for reporting this measure. With your consultant, we'll go into your EHR, find the report that does this, and input the numerator and the denominator, the how many instances there were available for e-prescribing and how many times it was actually done. Our system will do the calculations to find out what your score is. And we'll do that for all of the base measures, as well as any additional measures that you want to report on. Improvement activities are 15 percentage points. And as a note, what I recommend to my current clients who just want to avoid the penalty that they use to report, it gets the 15 points. You attest to activities that your practice is more than likely already doing. An example on the easy end of that is, are you making reminder reach out to your patients via email, via postcard, phone calls, patient portals, however it is that you want to get in touch with your patients to say, hey, Jane, we're looking forward to seeing you tomorrow for your physical, or Jane, we're so sorry you weren't able to make your appointment last week. Let's get you rescheduled. Or, Jane, it's been a whole year since we've seen you. Let's get you in to check up on things. Any of those work, whatever the format is. The measures do go to the more difficult side, too. They go to an anticoag clinic. They'll go to prescription drug monitoring, so on and so forth. Again, something that your consultant is going to be able to help you get through. Reporting on improvement activities is a matter of attestation. You go in, we select the measure, you click a button that says, I attest that we do these things in our office. The caveat comes with, do you have it documented? Can you show, should you be audited, how you do these things? I always encourage strongly that my clients write it up, have a policy and procedure in place. This is how we do this, whatever the activities are. Depending on the size of your practice, you'll need somewhere between 1 to 4 measures for this. Cost is new this year. It wasn't calculated, well, that's not true. It's always calculated by CMS. It wasn't used as part of your MIPS report for 2017. It is for 2018 at 10 percentage points. That will change in 19, but for now, it's 10. Cost is calculated and scored by CMS from the claims data you send them, starting at the beginning of the year. That has been going on every year forever and ever. It's just this year it's starting to be counted. It is scored by two different pieces. It's scored by attributed beneficiaries. What does that mean? That means, does CMS think that your practice is the primary medical care source for their patient, their beneficiary? This frequently is for the PCP. It can, depending on how you work, be for the specialist. That is something, frankly, that we guide our specialists to try and avoid by having the patient see their PCP at least once during the year. It is also scored by Medicare spending per beneficiary. So who are we reporting for? Who has to do this? Physicians of all stripes, PAs, NPs, clinical nurse specialists, and CRNAs. Physical therapists and such do not have to report until next year. Who's excluded? Those who are newly enrolled. So if you have a new clinician on staff who just graduated and is still so new that they're shiny, they don't need to report. If your practice is participating in an advanced payment model, you're getting 25% of your Medicare patients or 20% of your Medicare patients are seen that way, then you don't need to report. If you're below the volume threshold, that is that your clinician has not billed more than $90,000 a year or sees 200 or fewer patients in the year. If you have a significant hardship exemption, this can run the gamut from you're in the middle of, let's pick on Idaho, and your internet access is incredibly low. That can be considered as a hardship exemption. Recently, we had an EHR let us know that they are not going to be able to calculate some of the pieces of promoting interoperability correctly. That has led to a hardship exemption from CMS. So this really just depends on what's going on. CMS is the final word on whether you're eligible for a hardship exemption, however. Extreme and uncontrollable circumstances, those fires in California, the floods, so on and so forth, that is determined by CMS based on location. It's automatically applied. The rest of us need to report. So the way we guide, way we check, way we help our clients figure this out is to go to the QPP website and look up using, using the doctor's NPI number. So I've said a lot of times through this that your consultant is ready to help you. It's true. You're assigned a consultant once you register and once you sign up with us, who is going to guide you through, answer any questions, help you get from, again, point A to point success in this. It is your consultant. You can talk with any of us, but you're assigned one who's really going to do the verbal hand-holding through this entire process. We're always happy to get you started. I myself love having a new client come on and working with them, finding out what makes their practice tick, what challenges they're facing, and how they need to get this done. So we can help you create a plan that's going to avoid the penalty, whether that is the relative ease of the 15 points to keep from getting the penalty, to optimizing any potential bonus, to getting the most points possible. We're going to help you select the right measures. We're going to help you improve your performance. Given that it's December, we may not be able to improve much of anything between now and the 31st, but we certainly can help you work on how you're going to do this next year. We will also take care of the submission to CMS for you. Should there be any questions from CMS, we are here, we stand behind you, beside you, to make sure that any issues that CMS sees or notes are addressed and taken care of. I will say, knocking wood, that has been an incredibly rare occurrence. I can think of two over the past 3 years that I've been working here, that this has been an issue. And frankly, it was on CMS's side, not to point fingers. We have plenty of resources on our website. You can find the final rule for 2018, and we're working on the final rule for 2019 data as well. We can give you a guide that's on our website, and you can download it here. Again, you're going to get this slide deck through, you can either download it now or it'll be emailed to you. So I'm ready for questions. Red, is this a new question?
Yeah, so as part of the kind of work up to the webinar, we reached out and or had several of our partners reach out with some pre-submitted questions. So I've got a couple of slides here that you're welcome, Hadley, to just go through and answer. I think there's just a handful of pre-submitted
Great.
questions, and then we've also opened up the question box in the GoToWebinar control panel. So if you look on the control panel on your screen, you'll see a tab that says questions. Anyone is welcome to submit any of the questions that they have, and Hadley will be able to address them.
Excellent. Well, let's start with Amber's. What is the minimum points to avoid penalty and the simplest way to meet the requirements? Great question. The minimum points are 15. If you report less, you're going to get a penalty. A little bit more, you're going to, well, nothing really is going to happen if you report a little bit more. But the simplest way to do this is with improvement activities. It is a solid 15 points. It gets you where you need to be. As I mentioned when we were looking at the slide, an improvement activity is, let's use some different examples. Registering for the prescription drug monitoring program is an example of a medium weighted activity. So if you have fewer than 15 doctors in your practice, you would need another activity to do that. Another example of that might be, do you have a standard process for tracking and relaying the results of orders, whether the orders are getting lab work done, getting an x-ray, or what have you? What is your process for making sure that what the doctor says, I want labs done on Jane, translates into getting those labs done and then getting a timely result back to Jane for that lab work? I'm going to go on to the next question. Janelle, great name. What needs to be gathered to report claims by registry? So that really depends, Janelle, on whether you want to go for an incentive. I'm going to assume you do based on your question. To do that, we'll need to have your claims data. That means your billing data, the name, date of birth, date of service, CPT, ICD-10 codes for each and every visit by all your patients for the entire year for all payers. CMS this year, well, and last year too, wanted not just Medicare patients. That has been a huge question for several clients. Don't you just want Medicare? No, CMS wants everybody. So we get all that data from you, from your billing company, and use that to determine measures. We also can take QRDA3 reports from your EHR. Those, I will admit, are our favorites. It makes the work a great deal easier on our client side, so that's great. We also can take electronic billing files. All of these are the first step to starting your report. The rest of the pieces, improvement activity, is a conversation. Promoting interoperability is working with you to pull a report from your EHR to find the numbers for the measures. Let me rephrase that. To finding the numerator and denominator numbers for the base measures. How can we help practices prepare? Well, by going over the data that I just referenced to take a look and see how you're doing. Let's use our measure 1, A1C, as an example. If we get your data and we see that you have 300 diabetics and you've only had the A1C run on, well, let's be really exorbitant and say 20 of them. That's really not good. We want to see, CMS more importantly wants to see, and patient care would mandate that you do a more complete job of ordering A1Cs for your diabetic patients. So we're going to be able to see that from the data you sent us and from the analysis that we run. So that's a conversation we can have. You know, hi, Janet, I see that out of your 300 diabetics, only 20 have had their A1C done this year. Let's work on that for next year. Let's work on improving those statistics. So that would be an example of how we would help that. We use the data that you give us to see what doctors are ordering appropriately, how many it's being done for, whatever the measure might be. I hope that helps answer that question a little bit. Rose, that's a great question too. If you are not an EHR system, you wouldn't be able to report promoting interoperability. I'm assuming that you're on paper. If you can't report promoting interoperability, that means you can't get those 25 points unless you can apply for a hardship exemption from not to mean that you can't have an EHR. That, as a note, is something you must get done immediately. The deadline for that is 12/31 of this year. So, but back to your options. We absolutely can try to do a full-on report for the quality end. That comes from the billing data. We know who is eligible for what measures and what measures you're eligible for. The problem, the reason I sound hesitant on that is it's a lot of manual digging if you have to go into each and every chart for each patient that you are wanting to report on for the measures. So let's put a pin in that for a second. You send us your billing data. We figure out what measures you can report on. We figure out who needs to be reported on for the measure. At that point, then, your consultant is going to want to keep the reporting population low. CMS requires that you report on 20 patients with at least one Medicare per measure. So if you have an option of doing, we're going to continue with measure 1, reporting on 700 diabetics for a measure and a paper system versus reporting on 12,000 patients for measure 130 med reconciliation, we're going to strongly recommend that you report on 60% of your diabetic patients and not report med reconciliation. That's the medication report. I hope that didn't just confuse the issue, Rosie. If it did, please feel free to reach out to me and I'll go into more detail on that. The simple answer is we can help you. We can get this done. It's going to be more difficult to make more points without a hardship exemption for your PI, your promoting interoperability, but we still can get this done. If, however, you just want to avoid the penalty, we're going to go with an improvement activity report. That will get you your 15 points to avoid that penalty. Red, were there other questions?
It doesn't look like any other questions were submitted, so I think we're probably good to wrap up. We can stay live for a few minutes if there are additional questions. Again, feel free to submit your questions in the control panel question box, and Hadley and I can address those as they're posted.
Absolutely. Otherwise, let me tell you just a little bit more about Mingle. We were started by Dr. Dan Mingle in rural Maine. He just took a look at where healthcare was going, and he said, "You know what? We really need to work on this." Started a small company in the bustling burb of South Paris, Maine. It's absolutely gorgeous, so it certainly has that going for it. And we've been in business for the past 5 years, I believe it is. We recently merged with a company in Salt Lake City, so we've got that excitement and hustle going with us. We've been together for, I want to say, 4 or 5 months now. We're still there to work with you for everything, help you get this done. You can register at minglehealth.com. It takes you right through it. Your consultant will be assigned and will be ready to answer any questions. You also can, as we've said, email any questions to me, put them in the chat box, or you can just simply reach out, give us a call, or use our chat feature on our website. There's always somebody here to answer your question or questions.
Thank you, Hadley. And thank you everyone who was on the webinar today. As a reminder, this webinar has been recorded. The slides and recording will be sent by email to you later this week. Remember that Mingle Health is your partner in the transition to value-based care and helping providers and practices improve on what matters. Ask us how we can help streamline workflows, improve quality scores, and increase earnings. If you have additional questions following this webinar, please feel free to reach out to your quality consultant for follow-up. Thank you for joining today's webinar and have a wonderful day.
Thanks, everybody.